The Australian Dental Council and overseas registration exams exert immense psychological pressure on candidates. Success in these environments requires more than isolated anatomical knowledge. Welcome to the Australian Dental Council Explainer podcast. This content is purely educational, designed to assist with clinical reasoning, and is not a commercial endorsement. The ADC and ORE exams explicitly evaluate a candidate's ability to synthesize scientific evidence, technical skill, and ethical judgment under pressure. Rote memorization often fails when faced with the unpredictability of a clinical exam. To manage complex presentations, candidates need an adaptable, algorithmic problem-solving framework. Odell's Clinical Problem-Solving in Dentistry provides the standard model for this exact pedagogical framework. In this episode, we will analyze Odell's taxonomy, examine acute complication protocols, and evaluate chronic condition management guidelines. Mastering the Odell methodology focuses on the development of independent clinical reasoning. Odell's text covers the full scope of oral healthcare, organizing 75 distinct clinical scenarios. This contents page demonstrates the breadth of the material. The focus shifts from restorative issues like a failed bridge to trauma management in a skateboarding accident, and to oral cancer. Without a taxonomy, applying this volume of information during a timed assessment is difficult. The solution categorizes these 75 cases into a 4-pillar diagnostic matrix. Pillar 1 addresses restorative and prosthodontic management. Pillar 2 manages pediatric and orthodontic concerns. Pillar 3 focuses on oral medicine and pathology. Pillar 4 organizes oral surgery and systemic management. Odell applies a consistent methodology to every scenario, establishing the presentation, forming a differential diagnosis, selecting investigations, and drafting an evidence-based plan. This matrix provides a structured framework. When a candidate receives a case, they categorize the patient into a specific pillar to isolate the relevant protocols from distracting clinical noise. We can observe the application of Pillar 4 by examining the management of medically compromised patients. Odell Case 44 details specific requirements for a patient with a prosthetic heart valve taking anticoagulants. This flowchart illustrates the decision-making process. The primary step is assessing the patient's target INR level before beginning any minor oral surgery. Certain clinical triggers, such as an unstable INR, mandate a direct consultation with the patient's cardiologist before the medical team proceeds. Management relies on local hemostatic measures, including precise suturing and the application of oxidized cellulose to stabilize the clot within the socket. For postoperative care, the protocol suggests the adjunctive use of tranexamic acid mouthwash. Evidence-based guidelines state that the dental practitioner should not independently alter a patient's systemic anticoagulant regimen. In an ATC scenario, the candidate must prove their surgical plan respects these systemic risk parameters. While chronic conditions require careful planning, acute systemic emergencies demand an immediate, protocol-driven response. Odell Case 22 focuses on the presentation and management of hypoglycemia in the dental chair. This timeline charts a hypoglycemic event. The immediate step is rapid blood glucose monitoring. For a conscious patient, the primary intervention is oral fast-acting carbohydrates. If the patient becomes non-responsive, the protocol shifts to intramuscular glucagon to stimulate glucose release. These scenarios verify a candidate can pivot from a dental focus to a life-saving protocol immediately. Post-operative complications are another core testing area, specifically localized swellings as seen in cases 32, 49, and 63. The clinician must differentiate between odontogenic origins, like pericoronitis, and non-odontogenic facial pain. Alveolar osteitis, or dry socket, is a frequently tested acute complication following an extraction. The diagnosis is based on a specific triad: reports of severe pain, a distinct foul smell, and inflamed gingiva localized to the extraction site. This typically occurs 3 to 5 days post-extraction and is most common in mandibular molar regions. Management begins with atraumatic irrigation using either chlorhexidine or cerol saline to completely remove debris from the socket. Following irrigation, an obtundant dressing such as Alvogel is placed in the socket for localized relief. The pharmacological protocol focuses on systemic analgesics. Antibiotics are contraindicated for dry socket unless there are clear signs of systemic infection spread. Prioritizing localized palliative care over unnecessary antibiotic prescriptions demonstrates the evidence-based restraint required by the ADC. In clinical assessments, patients rarely present with a single issue isolated from their medical history. This diagram illustrates a common exam challenge, intersecting clinical parameters, such as an acute pericoronitis extraction in a patient with bleeding risks. The Odell algorithm provides a clear path: address the pain, reconcile the surgical need with systemic guidelines, and formulate a care plan. True success is found not in merely memorizing 75 cases, but in applying the diagnostic algorithm that connects them. Clinical competency integrates scientific evidence, flawless technical skill, and ethical judgment. For more dental examination preparation tips and clinical deep dives, please subscribe and share this episode.